Awesome, thank you. I had this complex slide set in 10 minutes and all these numbers. So I thought to myself, it's postprandial, let's make this more fun and interesting. And instead of getting too micro and in the weeds, I said, let's start from the macro down to the micro. I already got some attention. I love that. So the first point is when you look at what's the end point. We're all born, life's a journey, we are going to die. The end point is you're going to die. So, but having said that, it's a journey. And what endpoint are you looking at? The treatment endpoint, is that just for the procedure? Is that for you as an operator? Is that, so I was thinking through all of this. I have no relevance. So first is, we're talking about CLI treatment endpoint. What is critical limb ischemia? It's the end stage. 1 to 3% of all patients who have PAD. And you have either rest pain 4 or you have wound 5, 6. And if they are not revascularized, means there's not enough blood going there. The tissue is going to die and the leg's going to be gone. And a yogi told me this a long time ago. We are designed to move as humans. That's why we have feet and we love locomotion. Otherwise, we would have roots. So having said that, we as humans like to move. The more we move, the more we are better. So what's the end point? Just having a leg or being able to move? So I started thinking through this. Now, if you still don't treat CLI, you're going to land up with gangrene and disease and infection, etc. And knowing that this, if you don't treat CLI, it's going to lead to limb loss. So now how do we manage it usually? We know there's no drug for this. Now we have drugs that will help prevent the progression of disease and keep whatever you've done open, but revascularization is the biggest thing, it's the mainstay. Now, if the treatment is worse than the disease, that's why in the past you didn't treat claudicants, because the bypass with morbidity, mortality was higher, and they were said, go walk. Now as treatments become easy, so now you reserve bypass for more when they fail, and you're doing more endovascular work. And then say, how do I reduce this risk of something happening? So that's where we put smoking cessation, lipid lowering, cardio, and then you're looking at the male and the MACE and everything else. But in the end, you want to keep patency, whatever you've done. So then the goals become, I want to restore pulsatile inline flow to the foot. That'll make the tissue heal, make the wound heal, relieve the rest pain, and avoid major amputation. Now, does that happen at the time you do your procedure? Is that the endpoint? Or is the endpoint after you've done your procedure and now this human being is going to have his leg healed, the wound's healed, he's not suffering from it, and now is the endpoint where they're going to move? So that's where preservation of mobility happens. Because you may have a patient who's comatose and you're preventing amputation, and it's in hospice. Why are you going to do this? We run into that all the time because some family member wants this. So that's another point to look at, and that means improvement of patient function and quality of life. So that comes to the discussion of endpoints of treating CLI. Because I've had families come to me and they have a parent who is demented, is not functional, has a wound, they've been told they may get an amputation, and now they want us to do all these complex procedures. The institutions are worried about medical, legal, so they are pushing for the procedures. Now there's this debate going on between a vascular surgeon, a cardiologist, a primary care doc, and myself about what should be done. And that's where the question of endpoints of treatments come into play. So assuming first that you have ischemia, first is limb salvage. The second is outcomes, technical success. As trained tons of fellows, everybody says great angio, great flow, but there's no perfusion as we were talking earlier. So those become secondary outcomes of technical success. It was like the procedure was a success, but the patient died. Then we talk about CLR. Now, endovascular procedures, to repeat them, is not as morbid, or mortality is not that high, and the cost is not that high versus doing a very complex surgery. That's where the target lesion revascularization comes in. And even that discussion, there's so many papers, there's so much numbers of CD-TLR, what TLR, this technique, that technique, and everybody kind of gets lost in that. So I said, let's come back to it and look at it where you want to do a revascularization procedure that will stay open as long as possible. And what is good in your hands? You go to Midas, you're going to get a muffler, even if you got problems with your brakes and your car and your tire is broken. So obviously, if I have skills as endovascular, I'm not going to be good at surgery, and vice versa. So having said that, that's another point to look at in terms of how we're going to look at the endpoints. This next, obviously, is overall survival. I've had patients come be presented to us who are literally looking at hospice, and we've been asked to revascularize them. Now, yes, I can get the flow going, I can do all these procedures, but is that the endpoint I want? That's part of that very important discussion that needs to happen because CLI treatment is expanding fast. People are living longer. We are hunting for PAD. We are hunting for these patients. And now more and more procedures are being done. The people who pay for this are obviously aggressively pushing back. And that's why this discussion of what the endpoints becomes important in this. And of the ones, assuming the quality of life and survival part is taken care of, then you got to look at what is the amputation-free survival. Now, I've had patients come to me who, this was a relatively young lady, went through complicated procedures, did everything else on one side, and ultimately landed up with an amputation. And this is the wife of a attorney who is a medical legal attorney, calls me. And he trusts me, he likes me. So he calls me, he goes, Romi, can you please talk to her? I talked to her, I said, listen, we could help you on the other side. She goes, no, I don't want to go through that crap. I just want an amputation. I learned how to deal with it. And for her, that was the end point. And one other important point in this, in terms of CLI treatment endpoints, is engage the patient in that conversation. It's not about what numbers are good or et cetera, but the patient and the rest of the care team and say, this is the endpoint we're looking at. I've gone to lab after lab, I've done a lot, and then all they say is the angiogram's good, I got good flow, and that's it. It's stopped, the patient's gone, they've not followed this patient, nothing else has happened, they don't know what else is happening, and that patient has landed up somewhere else with a different endpoint, again, of looking at flow, and all these other endpoints are not looked at. So that's kind of part of one of my problems. So as a provider who is evaluating and considering treatment of CLI, what should they? First is be aware of all the revascularization options. This is not the ones doing it, but the others involved in the care and the team. Then select the most appropriate intervention or combination of interventions, taking that into consideration. What's the goal here? Now, I've had it on a patient who is potentially going to hospice in severe pain, with rest pain, with ischemia. They said, can you at least make it comfortable for the patient? So we did a procedure. We got enough perfusion, enough to relieve the rest pain, and the patient went to hospice. So that's one endpoint here. Some would argue yes, some would argue no. But in that care team, that was the decision. Patient was involved, care team was involved, everybody else was involved. The second is obviously taking what are the goals of the treatment. Now, in that patient who I'm trying to relieve their pain and make it palliative in a way for them, the risk-benefits ratio, if my procedure is going to kill them, why am I doing that? So that's another endpoint part of it to look at. And then also other comorbidities. You know, there are patients who've got COPD, who've got all these other problems. They are anticoagulated, they have bleeding issues, to kind of put that again in the endpoint. Versus just saying, I'm looking at this patency rate and this number and this flow and this stuff, and I think that's where we get lost a little bit. And finally, of course, life expectancy, which we've already talked about. So what we want to prevent when we are treating CLI, assuming all the other factors are good, is you do not want a major adverse limb event. You know, in the Society of Vascular Surgery, they have the objective OPGs, as they call them, goals. So you don't want to start an intervention and land up with a major amputation, and or you're constantly re-intervening on those patients. I mean, I've seen some places where they're literally every week doing an angio on that patient. That causes a problem as well. So that is one endpoint to consider. And obviously underlying is atherosclerosis, which means they're going to have a coronary problem, they're going to have cerebrovascular, and that discussion comes into it. And you also make sure that you're not getting them to where they're going to get to mortality. So it's important also to look at what's clinically driven TLR. Basically, and I bring this up because this has been a topic of discussion, especially I'm in the outpatient lab. I take care of a lot of patients, but there are labs where they're just bringing the patient in, just doing some stuff, sending them out, they're dropping the bill, and it's given us all a bad name. And that's where these endpoints become important. And that's the balance to be looked at. On a probably the only number I've thrown in here, is that you look at the ABIs, assuming it's valid, you did a procedure, the ABI is whatever, 0.8, 0.9. If it drops by more than 20%, you know that they're going to need some reintervention. But the endpoint there is, are you now getting perfusion enough to start healing the process, et cetera, to look beyond that. So in conclusion, first thing is limb salvage, that you look at that. Now, we've had patients who had a wound, the wound started to heal, but they have severe underlying ischemia. They've gone from 5 to 4, but it's a matter of time before this becomes 5 again and 6. So we've started to look at that and say, this is still part of limb salvage. And you have that discussion. And then you want to prevent major adverse limb events, major cardiovascular and cerebrovascular events, and avoid mortality. Thank you. The rest of it is the best.